Thank you very much to Robin Sagers, the academic head of WiSH, the Wits Sports and Health Research Group, for inviting me to chair tonight's session. And we're honored to have my senior colleague, Glen Vardi, to give us a talk on the dark side of the knee, the posterolateral corner. And I'll talk a little bit about Glen just now. Welcome to everyone who's joined us this evening. I see some orthopedic surgeons, physios, sports physicians, bios, chiros, podiatrists from all over the world and certainly the country. So I look forward to a great evening of listening to what Glen has to say, and then even more importantly, a little discussion at the end. So thanks to our sponsors at Sinolita for the great adverts and for their support in allowing us to bring this to you guys free of charge. And you get CPD points, so it's great to have you here. As you guys may or may not know, Glen is an orthopedic knee surgeon who works at the Rosebank Clinic in Johannesburg. He enjoys and specializes in knee surgery. He completed his undergraduate training at the University of Pretoria and specialized at UCT, where his kids are now, so he uses every opportunity to go back down there all the time. I hope it's standing after these fires, and hopefully we can get it back to where it was. After he specialized, he lived in the UK, where he completed 3 knee fellowships. Clearly, really wanted to learn his subject and a sucker for punishment. But thereafter, he worked at the Droitwich and London knee clinics, and then came back to South Africa in 2005, and had been in private practice at Rosebank Clinic ever since. He's a well-known speaker, teacher, and somebody who has always been highly regarded in the knee surgery world. And we're honored to have him give us this talk tonight and try and enlighten us on what's happening at the back of the knee. While he's doing that, and you're paying attention, on the bottom of your screen is a Q&A button. Please, we look forward to all your questions. Type them up, put them in there, and we're going to have a nice discussion at the end. Glen works in the northern suburbs of Johannesburg, so he's used to answering lots of questions. Everyone's got questions on everything, so don't be shy. He's got all the answers, and if he doesn't, he'll find it for you. So I look forward to the talk, which will be a great launching pad to a discussion. Glen, thank you. Over to you, and we'll see you just now.
So the posterolateral corner, the slides are not working now. Okay. So what is the posterolateral corner? It's a complex group of structures in the posterolateral aspect of the knee, and it essentially is all the structures from the LCL all the way around to the middle of the back of the knee, in other words, to the PCL. Injury to this or these structures are relatively rare. Higher energy trauma and knee dislocations often involve the posterolateral corner, and in a small percentage of patients, it's regarded as an isolated injury. More than 60% occur with PCL injuries, and then also one finds these occasional posterolateral corner injuries with ACLs. It's often overlooked, and in our rooms, we tend to focus on the ACL, and we look at the posterolateral corner when the PCL is injured, but we mustn't forget the ACL injured patient. It can then result in a failed ACL or PCL reconstruction if we don't treat all aspects of the injury. So there are roughly 28 structures at the back of the knee on the lateral side, and I won't go into all of this. The diagram and the anatomical diagram looks something like this. So essentially we're talking about lateral collateral ligament all the way around to the PCL. And there are lots of funny names here, and I will isolate it to something that we can understand. So again, be aware that it's thought to be responsible for failure of ACLs or PCLs in a large proportion of cases, and it can be elusive, so we must have an index of suspicion. So the three main structures, even though there are roughly 28 to 30 structures in that area, we focus on these three main structures, the LCL, the popliteus tendon, and a tiny little ligament that joins the fibula to the popliteal tendon, which is called the popliteal fibular ligament. So there they are, LCL, popliteal fibular ligament, and the popliteus tendon. What is the function of the posterolateral corner? It resists external rotation of the tibia at about 30 degrees of flexion, and that's how we base our clinical tests. And then obviously if the LCL is involved, we look at the varus valgus instability. The Americans call it varus rotation. The diagnosis is often, it's more important to look at the clinical picture. The radiological picture is less important, but nevertheless, we do look at the MRIs and X-rays. So clinically, any knee injury, it takes 2 seconds to look at the posterolateral corner and LCL. We have these fancy tests called the dial test, which can be done prone or supine. We have the external rotation recurvatum test. We have the posterolateral drawer test and the reverse pivot shift test. I struggle with the reverse pivot shift test, and I've often found the top 3 tests to be informative enough for me. So yeah, I prefer doing this test supine, not prone. The problem with this is that the knee moves to the outside. In other words, when you're doing this test, we have to make sure that the knee is not moving. We flex the knee to 30 degrees, and as you can see, this would be regarded as normal, and that is 10 or 15 degrees more external rotation of the foot. This is a lady that I saw a number of years ago with an isolated posterolateral corner injury. I didn't have to struggle or ask anyone to hold her knees together. She was so unstable, and in fact, her ACL, PCL, MCL were all intact. Her injury was ridiculous. She slipped in the bathroom, and she had an isolated posterolateral corner injury. In other words, a popliteus tendon pull-off, which is very unusual. It's the only one I've seen in 20 years. This is a pre-op patient, and if you look carefully, we've got more external rotation here. This patient was having an ACL reconstruction. I got the impression in my rooms that we had a posterolateral corner injury, and in fact, what's happening here is the assistant is not holding this knee straight. I think we're flexing this knee too much. This is the bad leg, and in fact, the external rotation is about 20 degrees here. We're letting the knee externally rotate, or the femur going to abduction, and what's happening is we're getting a false positive external rotation test here. So one has to be careful about holding the knees in place. In the significantly injured person, which you'll see now, it's not very hard, but a patient like this ended up having his ACL done, but no lateral collateral ligament or posterolateral corner reconstruction. The external rotation recurvatum test, I find this is more in the severely injured knee. So the multi-ligament injury, what happens here is we lift the toes up in extension and the knee goes into hyperextension and varus. So here is an example of that. This is not a normal amount of hyperextension. If we look at the same patient, it's a right knee injury, and let's run that again. So this LCL is quite lax. And if I run the video of the normal knee on the left, one can see there's, there's a bit of play, but not as much as on the right. I wanted to show the external rotation test. So her external rotation on the right is roughly 60, 70 degrees. I'm holding the patella facing upwards. If we look at the left normal knee, we've got something like 15 degrees external rotation. So I jumped a slide, you've seen that. I'll run these videos again just to show the LCL. So in a patient like this, the diagnosis is pretty obvious and not very difficult. She had a PCL injury at the same time. If we look at the arthroscopic findings, this would be regarded as normal. So we see the lateral meniscus, we see the articular surfaces on the femur and tibia, and the vision that we have is through a gap of roughly 5 to 8 millimeters. Obviously, people can differ individually. This is a posterolateral corner injury where we have what we call a drive-through sign, and this gap is up to 15 millimeters. One can see the popliteus in the background there. This video is not running, but it doesn't matter. This is an example of a severe injury to the posterolateral corner where the drive-through sign is significant, up to about 20 millimeters, and one can see the popliteus has pulled off the femur. And here's another fresh example of popliteus injury. If the popliteus has pulled off and this drive-through sign is positive, one can assume that that whole posterolateral corner has been injured, and one can also assume that the LCL is probably injured as well. The distance or this length of the tip of this probe is roughly 4 or 5 millimeters. So one can see this would be 20 millimeters. Radiologically, it's not very helpful. In the severely injured patient, we just see a big mess. In the ACL injured patient, we often get a report by the radiologists saying that the posterolateral corner has been injured, and then one has to look at it clinically. Because of the multiple structures in that area, we have to correlate it with the clinical picture. This is the same patient that I showed you, and you can see edema in the posterior and posterolateral aspect. This is a total mess. You cannot identify much there. Funnily enough, her meniscus is intact. This is the start of the LCL, but the rest is just a mess. Yeah, we see the MCL, and on the lateral side, again, a total mess with unidentifiable structures. There's the lateral collateral ligament starting at the top. One cannot see too much from these pictures, and clinically we know what this patient had. Axial views, same story. From lateral to the PCL, this you can't identify much here, and this is a severe injury. This is another patient who had a lateral collateral ligament injury. It's very difficult to identify much. This is the start of the conjoint tendon with biceps femoris and LCL, and then the rest is a mess. This is a normal MRI scan that I just wanted to show. We don't see this often. It's difficult to identify the popliteal fibular ligament, and in fact, yeah, you can see it very well, and it's quite a nice example. Yeah, you see the popliteus muscle forming the tendon, and here's the popliteal fibular ligament and the conjoint tendon with the biceps femoris and the start of the LCL. And that's a nice example of those three structures. How do we treat it? It's not really standardized. which patients would we treat conservatively and what are the surgical options. So conservative management in the less severe injury. If it's isolated with a dial test that is minimally different, so the stability is minimal and the patient's asymptomatic, we can watch them and treat them conservatively. I do an MRI scan and make sure the other big structures are okay. If we're going to go to surgery, we often look at repairing an acutely injured patient. So we want to, especially if there are avulsions, if large structures have been pulled off the bone, we want to fix them back like the LCL or the popliteus tendon. But as soon as time has lapsed, I see these patients in my private practice quite often in the chronic situation, and then it's difficult to recognize and put the anatomy together. But if one can, then I often do a primary repair, fix the avulsions, and then I may augment it with a reconstruction on this at the same sitting. If we look at the reconstructions, we are going to treat patients with surgery if they're chronically unstable. If conservative management has failed, I don't wait to see if we're going to, if there's significant laxity, I'm going to suggest surgery, especially if there's a multi-ligament injury. So if we look at the reconstruction options, I'd like to go into a bit of the history first. If we look to 20, 30 years ago, what they were doing is something called an advancement. So what they would do is they would take the soft tissues and pull it up. So we tighten the LCL, pull the posterolateral corner and fix it and tighten it all up, which is a bit of a strange thing now for us to even contemplate, because what happened to these is the problems are that, first of all, the tissue is often attenuated and you can't find nice envelopes of tissue to pull and fix, because it's often like tissue paper and you can't recognize some of the anatomy. And then you're putting it into a non-anatomical position, which creates an isometry, and then they would often fail due to attenuation. So that didn't really work. They then started looking in the 90s at a biceps tenodesis, which looked like that. So what you would do is take the biceps femoris, fix it to the femur. It would address the LCL, but the problem is you're not addressing all three structures. It's non-anatomic. It could over-constrain the externally and varus rotation, and then you take away the stabilizing effect of the biceps tendon. So that didn't work very well. So then they started reconstructing a portion of those three structures in the late 90s. And so LCL was dealt with, but it didn't deal with the other two structures. And these are two examples of that kind of reconstruction. And you would probably find 100 different examples using different tissues and autogenous and allografts, etc. But you aren't reconstructing the posterolateral corner with this. Then they started in the late 90s, early 2000s, doing what they called a popliteal tendon reconstruction, and they called it a sling procedure. So what you would be doing is addressing the popliteus, but not the other two structures. So it may deal with the external rotation, but not the varus valgus portion of the injury. So then someone by the name of Larson came with his Larson procedure, which was eventually modified into what we call the modified Larson procedure. And it essentially is a nice, neat procedure that dealt with the LCL and the popliteus. And that's what it looks like in the modified version. Larson had a single fixation technique here, which wasn't anatomical, and it was modified into this figure of 8 structure, which dealt with popliteus, perhaps dealt with LCL, and this was my procedure of choice up till recently, probably 3, 4, 5 years ago. Studies looking at the modified and the Larson procedure. This is the Larson procedure, single attachment site on the femur, not anatomic, preferred to have popliteus and LCL as 2 separate fixation points with a more vertical drill hole through the femur, through the fibula. Better results from this, and called them modified Larson. Then it became evident that we should be addressing all 3 of those structures. To remind you, the LCL, the popliteus, and the popliteofibular ligament. And along came a surgeon by the name of Leprard, who documented the anatomy and the biomechanics, and using a split Achilles tendon allograft for his first reconstructions on cadavers, and he essentially reconstructed those 3 structures with a neat anatomic reconstruction. So what he did was look at the fixation points of LCL on the femur, LCL on the fibula, and the anatomical fixation point of the popliteus. And he essentially developed this, or described this, very complicated looking but very good reconstruction of all those 3 structures. So LCL, or the Americans call the fibular collateral ligament, popliteus, and popliteus tendon. This is now regarded as the gold standard for the posterolateral corner LCL injury. And then came along a group of surgeons in the UK who modified his technique in the form of a technical note, which was published using a single strand autograft, in other words, semitendinosus. And I like this procedure, and I will describe it and explain what it is. It's essentially the Leprard procedure, but it's using a single graft, and it's nice when one has the need for multiple grafts in the multiply injured patient. So this is what it looks like. It is a loop single strand hamstring graft, which then divides into the LCL and the popliteus tendon, and you can alter the length of this loop, and it's an adjustable endo button type of fixation is used in the tibial tunnel. This is my standard procedure now for a posterolateral corner LCL injury. This is the reference for that technique, and I think if surgeons out there are doing this procedure, it would be, I would strongly suggest they read this article. I think it's brilliant. So some tips and tricks for the surgeons. Obviously, you have to know the anatomy. You have to know where the fixation points are and where the structures fix onto the various positions. Create the slots and tunnels and pass your pull-through sutures or wires first. Be ready with all of this before you get ready with your graft. Remember, the popliteus is underneath or deep to the LCL, so do it first. I have at least 15 millimeter, or I aim for 15 to 20 millimeter graft in the bone. Aim the femoral tunnels anteriorly and proximally. If you've done an ACL or PCL, especially the ACL, you might get convergence of tunnels and drill through your ACL graft. Identify and dissect and free the common peroneal nerve. So I have put a question mark there. I only do it in an acute injury when there is a complete mess and there is a nerve injury. Otherwise, the drill holes and tunnels are quite far away from the nerve, and I don't routinely, in a nice cold case where there's no nerve injury, I don't dissect the nerve and I don't even look for it. The tunnels are quite far away from the nerve. That's just my personal opinion. The attachment points of popliteus and LCL are deep to the ITB, so the ITB can be split, and sometimes we have to do a double split in the distal ITB. Remember, the tibial, these grafts come out just hugging the tibia, and therefore they are deep or anterior to the lateral gastrocnemius tendon. There are aiming devices for the tibial tunnel, which are quite helpful. I use my finger at the back there, deep to the lateral gastrocnemius, and I think tactile sensation works better for me. I then use 6 millimeter drill holes for the LCL and the popliteus tunnel. This is technical. These are the technical aspects that you will find in that article or in Laprad's articles. I won't harp on this too much. The fibular tunnel, 5 millimeters. The tibial tunnel is 7 to 8 millimeters using the endobutton or an extendo button. Remember, other procedures may need to be done. So do your PCL, do your ACL. In the chronic patient with a significant varus deformity, sometimes we may need to do a high tibial osteotomy to correct the varus first. Often these patients don't come back for the secondary soft tissue reconstruction because the high tibial osteotomy corrects the varus deformity, and the soft tissues sometimes contract and they feel happy enough to carry on without it. So here's an example of an HTO that has been done in a previously reconstructed, failed vertically placed ACL, but an intact PCL. This patient had the varus corrected with the high tibial osteotomy and then did not return for the ACL when he was chased. He said he was completely happy with his knee and didn't come back, and that was done in 2003. The rehab I'm not going to go into too much detail with, but essentially one has to work out what have you done and what ligaments have been reconstructed and adapt the weight bearing, the range of movement, the use of a brace, and limitations of range of movement depending on ACL with posterolateral corner on its own, or PCL with posterolateral corner. So any posterolateral corner patient has a brace. I don't use a brace for an isolated ACL. I do use it for PCLs, and then obviously for the posterolateral as well. And then the weight-bearing status will be dependent on what else you do. So I won't harp on that. So when one starts talking about the nerve, the common peroneal nerve, you can see that the fibular tunnel is essentially quite far away from the nerve. And if you flex the knee, the bowstringing effect or tightening of the nerve is reduced, and therefore the nerve moves further away. But I will have some sort of protection over here so that I don't drill right into the nerve proximally. Just remember that if you know that you have protected the nerve and you've been retracting, if your assistant has been retracting for you, or you have continually palpated the nerve digitally just to make sure you're far away from it, these patients can wake up with a dropped foot, and just don't panic. It usually recovers as long as you know you haven't drilled right through and over drilled your tunnels posteriorly. And if you've followed the rules with protection or instrumentation, either with your finger or with instrumentation, then usually you're okay, and the drop foot responds within a day or two. One thing I would suggest is make a pre-op note of nerve function if you're going to deal with patients that have had significant injuries to the posterolateral corner. It will protect you legally if you have pre-noted a drop foot. The patient doesn't want to wake up and you don't want the patient to wake up and sue you. Make sure you have informed consent and that the risk of nerve injury is a possibility. And if the patient wakes up with a drop foot, make sure, just reassure the patient that we'll watch it for 48 hours, and usually these patients settle down and their foot function and sensation returns to normal. So that is my talk in a nutshell. Brad?
On the way, Glenn, thank you very much for a great foundation and basis of managing these what can be very complex injuries going forward at all. Now is the time for everyone to pay attention, type in your Q&As, and let's have a good discussion about the way forward. I see a lot of rehab people on the talk tonight, Glenn. You mentioned the brace. Are you worried about the tibia being externally rotated or pushed into varus when they rehab it? And do you give the physios any specific precautions when they're rehabbing the patients?
So if I have an isolated posterolateral corner and LCL injury, which is very rare, then I would provide them with a brace. I would allow full range of movement, but I wouldn't allow weight bearing. So it would be non-weight bearing for about 6 weeks. And then depending on how happy I am, I might continue with non-weight bearing for another 6 weeks and then do touch to partial weight bearing for the second 6 weeks. At 3 months, I don't think whatever you're going to do in terms of weight bearing, you've got what you've got and things will not change. In terms of varus valgus, I think that's what I'm using the brace for. And it's really to keep people away from this patient. You know that I'm not a big brace fan, but if I've done a posterolateral corner, I'm essentially using the brace to slow the patient down, to protect the varus valgus and the LCL more than the posterolateral corner. And I do allow full range of movement with non-weight bearing. If we then get to the patient who's had a posterolateral corner LCL with an ACL, then my regime will follow the posterolateral corner in terms of weight bearing. The ACL and the posterolateral corner would allow full range of movement, but the weight bearing would be limited as for the posterolateral corner, and I would remove the brace at 3 months. If I've done the posterolateral corner LCL with a PCL, then I start looking at how I would treat that PCL. So it would be non-weight bearing for the posterolateral corner for 6 to 12 weeks. But the PCL takes preference with regards to range of movement, which is 0 to 90 for 6 weeks, with pressure every time one flexes, with regards to preventing the posterior sag at 90 degrees.
Great. And so you're happy for the physio to protect your reconstruction and get the patients moving. That's awesome.
Yeah.
All right. Just a question for I see a few orthopedic registrars have joined us today, and I'm sure they're going to get this in the exam one day because I got it in mind. So if we get to ask some questions, they're going to get it too. When we look at the biomechanics, and there's a question that's been asked in the Q&A regarding the Wood's technique and the Leprard technique. Why is that more stable than the modified Larson? So when you do the Wood and the Leprard technique, we reconstructing the LCL, we then tenodecing the fibula to the tibia, and the popliteus portion is replicating the dynamic popliteus. So the question is, does the femur to tibia portion add much to better mechanically positioned femur to fibula graft, which is further out of the steering wheel and rotational? And that's from one of the surgeons around. So I don't know if you understand the question. Yeah.
Am I answering it?
Yeah, I'm answering it.
Lucky me. Okay. So for me, just reading Leprard's articles, I mean, there are many articles that compare the modified Larson to Leprard, and Leprard's results are biomechanically better. For me, just scanning over all those studies, I get the impression that overall everyone regards, and the results do show, that Leprard's biomechanical testing on cadavers, for example, are more close to the norm or the normal. So that's from a biomechanical aspect. With regards to the anatomy, if you look at that modified Larson, there's something missing out of that posterolateral tibiofibular reconstruction part. It's almost like you're doing half a popliteus, and this is just a non-scientific impression that I have. You're doing half a popliteus and you're doing half a popliteal fibular ligament, whereas Leprard's technique anatomically just seems more realistic and more accurate and more real, and it's following the specific anatomy of those three structures, whereas the modified Larson isn't. But I was happy with the modified Larson. It's certainly easier, it's quicker, and it's less technically demanding. But for those, so I might consider a modified Larson in the case that is just off. You know, clinically, the dial test is 10 to 15 degrees as opposed to, and the, as opposed to 20 degrees external rotation. And the external rotation recurvatum test is not significantly positive. So I might consider the modified Larson as a less intrusive, less traumatic procedure. But for that patient that I showed, where you've got a significant hyperextension, varus, external recurvatum, then I would not consider the modified Larson. Just as a broad-based principle, I think that injury is too severe for me to consider the modified Larson. And it's a clinical impression rather than a scientific classification and, you know, choosing based on science.
I think that's a great summary. There's a follow-up question on that, and then I'll maybe just close this discussion. But the question, isn't the popliteal fibular ligament really a dynamic structure? And when the popliteus contracts, it tightens the PFL. We're therefore reconstructing a static structure. And I think maybe just to put it in perspective, I think ultimately we as surgeons need to have lots of different options available. And I like the way that you stratify it depending on the amount of instability. And I do think that that tibio femoral limb, in my opinion, is more of a posterior capsular structure than a popliteal structure. And actually just, for me, stops at hyperextension. And therefore, I agree with you absolutely that those hyperextenders with that really big recurvatum probably do benefit from that technique. So I think the message that you give that I'm going to take home is that we need to have all the different arrows in our quiver, and we pull the right one out when we need to. So I'm going to put that to bed. Finally, everyone's typing beautifully. So we've got lots of great questions coming in.
And I
So
just, the popliteal fibular ligament is a static structure, but it's the popliteus that pulls it. And it's the muscle of the popliteus. So the tendon of the popliteus is also static. So I suppose the tension in that tendon will change, but the length of the tendon doesn't change. And the length of the popliteal fibular ligament doesn't change. So you're reconstructing static structures. And I think all you are doing, to echo you, Brad, all you are doing is reinforcing that posterolateral capsule with sort of what we would regard as the main structure. And hopefully with healing, everything will just stick down and become more stable. For a severe injury, the results are not going to be fantastic unless that whole back corner does heal. So in the acute situation, if you've supported it with an augment, I think you'll get sticking down and scarring of that posterolateral capsule, and hopefully it'll be stable enough.
Great. I'm going to move on a little bit. I see one of the questions asks about how a posterior lateral corner chondroid lesion is managed. So I'm not going to answer it now because I'm not sure exactly what you mean. So the person who put that question up, can you just explain what chondral lesion it is? Is the femur, tibia, fibula, where it's coming from? And we'll get back to it just now. Got a rehab question, Glenn. Why are you limiting weight bearing? What are you protecting in the weight bearing side of these patients?
So if the patient has a propensity to varus and they walk into your rooms with, from one side of the spectrum to a minimal varus as they walk, like a lateral thrust patient, to a significant chronic posterolateral corner injury, I don't want to reconstruct the soft tissues and have them stand on it again and thrust laterally. So even if they come in with a minimal, because if I'm dealing with these patients acutely and I get varus valgus instability, that means if they have a propensity in a slightly varus, physiological varus knee, they're going to stand on it and pull my reconstruction to bits. So I want to give them enough time to heal before we start stressing them into varus. It would be less concerning if they are naturally a genu valgum patient, so perhaps women more than men, but I still wouldn't want to take the chance, and I would limit their weight bearing. And if they slip or fall, and they put tension on the reconstruction, they'll pull it apart.
So just to follow on from that, and you mentioned it earlier, patients who are on significant varus, you would consider doing a high tibia osteotomy to correct the varus to protect your reconstruction. There are a number of patients who are just small amount of varus where maybe an HTO is not ideal, and maybe those are the ones that you're aiming to protect, as you discussed. What is your cutoff, and how much varus would you consider significant before doing an osteotomy?
I don't know is the answer. I think judging clinically again, if I had a chronic patients, if I got these patients acutely, I would do all the soft tissues and perhaps not do the HTO. The patient I showed who had an HTO is the chronic patient who walks in with 10 to 15 degrees of varus, chronic soft tissue laxity. I would send them to you for the HTO. So a significant lateral thrust, a clinical impression, more than 5 to 10 degrees of varus, I would send them for an HTO. I don't do HTOs, as you know, So I would refer out.
Okay, so that's a great summary for the registrars out there, again, particular, and the surgeons for an approach to those sorts of patients. So thanks, Dan, on that. Just moving on to a little nerve stuff. If you suspect a common peroneal nerve injury, when would a nerve conduction test be useful in your practice? And then there's a question on neurodynamic slide and glide exercises, which I'm not so up to date with. I'm not sure if you are, and whether you would allow that post-op to protect the repair.
So with regards to the nerve, in the, let's call it minimally injured patient who's got an ACL with a 5 to 10 degree difference, or let's say 10 to 15 degree difference of dial test at 30 degrees, I'm going to do my posterolateral corner LCL reconstruction with my ACL. I am not going to, if they don't have nerve conduction, if they don't have nerve fallout, I wouldn't send them for any nerve conduction studies, and I wouldn't expose the nerve, I wouldn't protect the nerve, and I would do my reconstruction. I'm quite confident that my reconstructions are nowhere near the nerve. If a patient comes in without nerve damage, with full nerve function, but with significant laxity, like the patient I showed, I also wouldn't do any nerve conduction studies. I don't think it's necessary. So the only time I'm going to investigate that nerve is if they've got nerve fallout. So one has to choose between, well, we're going in to reconstruct, we are going to look at the nerve and see if it is damaged. I think it may be worth getting nerve conduction studies before one approaches it surgically to understand whether you have a complete transection of the nerve or whether there is still nerve tissue. Because if it's completely transected, you may want to get the peripheral neurosurgeon or a plastic surgeon in to repair that nerve straight away while you're there, so that you don't have to. I've done this a few times where the peripheral neurosurgeon who I worked with in the UK would say to me, do my stuff first, and then he would go back 6 weeks later to repair the nerve. It seems more appropriate to do what you have to do at the same time. So nerve conduction studies in that situation, determining if it's a complete transection, and then get someone in to help you at the same time. So you'll do your reconstruction, your soft tissue knee work, and then the peripheral neurosurgeon would take over and repair the nerve. The other question was rehab.
On neurodynamic slide and glide exercises, for example, passive straight leg raise with ankle inversion and hip adduction with a common peroneal nerve, and then adding forefoot adduction to sensitize the superficial branch of the common peroneal nerve. Would you allow that post-op? And if you don't know, that's
so
also an answer.
I would allow that. I'm not too familiar with that. If one has done a repair of the nerve, then you need to protect the nerve, and you wouldn't want any tension on that nerve. So it's straightforward, slide and glide, and range of movement, yes. Remember, flexion decreases the tension on the nerve. So from full extension, you would allow the flexion that is allowed for your reconstruction anyway. If the patient doesn't have fallout and we haven't exposed the nerve and we haven't done anything to the nerve, then yes, I would allow all of that with my reconstruction. Essentially, if the person who asked that question obviously has a fair idea of what they are doing, so my feeling is the patient is yours, go ahead and rehab the patient. In surgery, you don't tell me what to do, so I'm not going to tell you what to do with regards to your job. But yes, if you've done a repair of the nerve, things change a little bit because we don't want any tension on that nerve.
So the person who did ask that is a very well known physio who is excellent. I think it's a good answer. We've got a couple more questions just on rehab, and then we'll move on to some more surgical stuff. When you begin strength training, is there a range of movement which should be avoided in closed kinetic chain exercises? And then when and in what ranges would you advocate open kinetic chain exercise?
So I think for me that depends on the PCL and ACL status. So again, dividing into pretty much three types of situations, maybe four if one includes the MCL injury or dislocated knee. So going from isolated posterolateral corner LCL, which is very rare, full range of movement, open and closed chain. If it's ACL, then open chain introduced for the ACL by habit. Some studies have shown it doesn't matter anymore, but for the posterolateral corner LCL, I have no problem with it. For the ACL, we still stick to the roughly 3 months avoiding open chain, but full range of movement for ACL and PLC. And if it's PCL and PLC, then I limit range of movement to 90 and open and closed chain quads. Allowed.
Great.
Start.
So now we've done that, and your patients are moving, they're training, they're strong. What is your advice regarding return to sport with these patients?
Okay, so it depends. Again, clinically, I would judge these patients clinically. That example patient that I showed, if that patient was a professional rugby player, soccer player, squash player, tennis player, I think that career would be in jeopardy because I don't know, in my hands, I don't know if I'm going to return that patient to pre-injury level activity. So if we go to the other side of the spectrum where we have an ACL rupture and a minimally lax, but significantly lax to require a surgical reconstruction on the lateral and posterolateral aspect of the knee, that patient could return to sport, but then it would be within the parameters of the ACL. So I think once the ACL has returned that patient to sport at 9 months to a year, then the PCL has healed as best or as good as it can. Because essentially the PLC reconstruction is healed or is pretty much as healed as it's going to get at the 3-month mark. So essentially the ACL takes preference and the rehab focuses on return to sport at 9 to 12 months. Some people may push that to 6 months, but I'm a bit conservative with these patients. And I think if a patient has had either ACL or PCL with this posterolateral corner LCL reconstruction, I advise 1 year return to sport. So we start looking at multi-ligament injury patients. I tend to have my benchmark as the 1 year mark, even if they've fulfilled all the biokinetic parameters and clinical parameters. And I don't know why, I just feel more comfortable for a year.
Right, thanks. Let's get back onto the surgical discussion. I have a question here, and it starts off talking, and it asks about staged, single stage versus 2-stage reconstructions or surgery, and not just reconstructions versus repairs, in a PLC with a PCL. Where it's coming from is from somebody and certainly trainees who are seeing lots of multi-ligament injuries. And there certainly is the thought process that one can stage reconstructing certain ligaments at certain times. And I think they want us to try and clear that up, in our opinion, or your opinion. I'm just going to moderate.
Okay. So you guys are lucky or maybe unlucky to see these more of, you've probably as a registrar seen more of these acute, significantly injured knees in a month than I see in 2 years. So I tend to get these patients chronically, but to address that question, I would tend to reconstruct everything or fix everything to give this patient a chance, but one has to question what are the problems with doing significant multi-ligament injuries all in one go. And the obvious one is scarring and stiffening up of the knee and not gaining range of movement afterwards. So the patients should be warned about that. The other issue is that inexperienced surgeons might take long. So you're starting to look at 3, 4, 5 hour surgery with a risk of infection, open wounds. So, you know, one would have to strike a balance between risk of long surgery, scarring, and infection with quality of grafts, availability of grafts, and the know-how to slot these grafts in quickly under 3 hours. So you have to make that choice. And this is a very debatable topic. I am more inclined to try and get everything done one shot, because if you're going to do any form of repair, if those posterolateral and lateral structures have been attenuated or significantly damaged, you're going to want to reconstruct or augment with a reconstruction of sorts at the same time as you fix the avulsions, which you need to do. And if anything is pulled off with a piece of bone, their best result would be if you fix that back. And if the structure has stretched and attenuated at the same time, you might want to support it with some sort of reconstructive augment. And then you're not going to do that laterally and posterolaterally unless you look at the cruciates. If you're going to do one cruciate, then you're going to do the PCL, which is what is recommended if you're not going to do everything in one go, if you have an ACL as well. So I would do the PCL in the posterolateral corner. I would then rehab the patient and come back for the ACL if you can't do it all in one go. That is essentially what has been recommended. The nice thing, in a way, nice in inverted commas, is that if you get an ACL, PCL, and a posterolateral corner with the LCL, so if we talk about posterolateral corner, often that LCL is also gone. So I'll just say the three main structures, which is PCL, PLC, and ACL. The reconstructions of the cruciates is significantly easier than doing a PCL posterolateral corner, because when the ACL is gone or ruptured, it's so much easier to just do both cruciates because that ACL isn't in the way and your vision is good, and it shortens the ACL surgical time and the PCL surgical time significantly. So in my hands, I would just do all three in one shot, and it's done, and then we can rehab. But we have to rehab very diligently and sort of quickly, because these patients can stiffen up. So it's a balance.
I often say that these are complex injuries, and when I speak to our regs and our guys out there, certainly acutely, ideally, they should be managed in an environment and a place where a lot of these are managed. But if you don't have that ability in today's world, we can always get on the phone and phone somebody with experience, transfer patients, or get somebody on the line to help us, or get someone else to help us. And I think that is a take-home message. But
I'd like
thanks,
to,
yeah,
Brad, I'd like to echo you on that, because I recently had a patient who had an injury, ended up in a trauma unit somewhere, and a relatively inexperienced surgeon took this patient, reconstructed ACL, PCL, and posterolateral corner. In fact, I think I discussed this patient with you. And in fact, got the femoral tunnels completely wrong for both the ACL and the PCL. I had to revise the ACL and the PCL. I had to reconstruct the posterolateral corner using synthetic grafts. Both patella tendons had been used, both hamstrings had been used, and I was in a bit of trouble. And I'd like to echo Brad that I'm sure Brad would agree with me that most of the guys who call themselves knee surgeons would be totally happy coming along and assisting you with one of these cases, holding your hand, and or at least discussing it with you on the phone, and maybe even putting this patient on our list on a Saturday or something if they have medical aid. But we would be only too happy to come along and hold your hand and let you do the surgery. You know, that should be a thing that you guys should be aware of, and we would be only too happy to assist you.
Just a comment and a question before. We've got about maybe 5 to 10 more minutes left, guys. Just a quick plug for those who want to put their questions in. Now's your chance. Otherwise, we're going to be wrapping up soon. Get typing those fingers. In terms of repairs, Glenn, on the lateral side, you know, it's something I know certainly when I was a registrar, and I know it gets taught that in a multi-ligament injury or these sorts of injuries, one should just quickly go and open up and do an open repair and put everything back where it belongs, which often sounds a lot easier than it is, because I've tried that once or twice, and like you said about those MRIs, you use the word mess, which is a great medical term that I find, but it really is a mess. What is your experience with primary repairs of these? Is it something that you think one should be attempting on a regular basis?
If you're going to go in, you're going to make your incision, and you in the acute situation, you might find that the whole collar of the lateral and posterolateral structure, or the collar of structures, has pulled off, and sometimes you get a slither of bone coming off the fibula, and maybe, if you're lucky, off the proximal tibia. But one has to assume that even if you do fix that back, and it's very rare that you see it as nicely, I agree with you, that anatomy has been pulled apart, stretched. It sometimes looks like tissue paper, and it's just not feasible to repair. And so the repairs mostly in the acute situation, we talk about the avulsions, which, if I get 10 of these, I might have 2 patients that I can fix avulsions back. But I also don't trust what is left behind, and I would usually augment it either with a modified Larson or with a Leprod, because I just don't trust that what I've got is stable enough and thick enough to work. So I usually augment it in the acute situation. Sometimes, I mean, it's very rare that you just get the LCL with a little bit of that cuff of posterolateral corner, in other words, the popliteal fibular ligament, and all you need to do is pull that collar down and fix it to the proximal fibula, and essentially that's a decent repair. If your knee is stable, then and you know this patient hasn't been significantly injured, you might get away with that. But I agree, it's not always possible, so I augment it.
All right, so the last question currently, and it's something that I don't see much of, but the questions regarding a chondral lesion of the femur and or tibia at the same time as this injury, and particularly in the lateral weight-bearing surface and how you would manage it. Do you see these often related to this? And what do you do? Oats, microfractures, leave alone? Yeah, your thoughts.
Okay. So a posterolateral corner injury is usually a traction injury. So the person classically falling off the horse or getting hit by a bus, if they are going to go into varus and stretch that whole LCL posterolateral corner out, you know, unless you're getting a chondral injury from the recoil, if we're talking about chondral injuries specifically in the on the lateral side, but the management of the chondral injury would be as you would manage any chondral injury in any knee injury situation, not specific to this particular topic. If I'm doing an arthroscopic guided reconstruction of any ligament and I see a chondral injury, I would manage it with algorithms according to how deep it is, how widespread it is, how unstable it is. So I would stabilize in the acute situation. I'm not going to consider anything like an oats, and I've never done an oats on it. In fact, on a tibia, I once considered it, and another patient did an oats on a tibial lesion, which worked reasonably well, but I've never done a tibia. The oats procedure is a last resort procedure that's never done acutely. You would still manage the instability of the chondral lesion by removing fragments, stabilizing the lesion, and if anything, doing for a grade 4 lesion, doing a microfracture. You wouldn't go consider any oats procedure in the acute situation. These patients will have a lot of, especially if they are young, they'll have a lot of blood in their knee, a lot of healing factors, stem cells, etc., because of all your tunnels. So I think that would be the start. And if they have large chondral lesions, then they're in trouble. But you'd still manage it by removing, stabilizing, and bone marrow stimulation if you want to.
Great, thank you, Glenn. That was a really excellent talk, and I think a great discussion. And thank you to everyone who attended tonight. I really think the last hour or so has been extremely informative. I've learned a lot, and I've done a lot of these as well. And I just want to thank you for your time in preparing the talk and for being here. Glenn is also the head of the WiSH knee interest group. And I see many people here who may want to be involved in WiSH in one of the interest groups. If you do, please reply to Nadine who sent you the link for this and put your name forward, and we'll get you involved as much as possible in that. I want to thank John Patricios and Robin Sagers for inviting us to be here tonight. I'm sure Glenn's glad to be sharing his information. And I want to just plug the next talk, which is our cricket interest group, which is going to be hosted by Dr. Lee Pillay. And it's a panel discussion on healthcare workers and biosport bubbles, or sport bio bubbles. That's next Thursday evening. If you go to the WiSH site, if you look on the screen now, you'll see how to register for that. We look forward to attending. I'm sure the talks will be quite interesting because the bubbles are quite interesting. Maybe they'll tell us what they actually do all day in those bubbles, because they can't be working all day. So what TV games they're playing. They're called the elephant in the room. So I'm not sure, it looks interesting to see what that is. So thank you very much to everyone involved. Thanks, Glenn. Thanks all for coming on tonight. Thanks to our sponsors.
Thanks, Brad.
And I look forward to seeing you all around.
Thank you.